So it's with great pleasure that I now introduce Pearl Pugh, our paediatric renal dietitian and lecturer from the University of Nottingham in the UK. Pearl worked as a Band 7 clinical lead paediatric renal dietitian at Nottingham University Hospital NHS Trust from 2002 to 2015, managing a wide range of patients with CKD. Pearl has recently completed a Doctor of Philosophy in Health Science at the University of Nottingham, exploring the development of an early dietary phosphate intake in children with early stage CKD to delay disease progression. Pearl presents to us today on the topic of phosphate management and diet to minimise cardiovascular disease. So during Pearl's presentation today, Pearl will ask you to vote in a poll. At the necessary time, the link to the poll will be put into the chat box where you can click and add your response. So over to yourself, Pearl.
Thank you very much, Lucy, and it's great to be part of this conference today. So thank you for that introductory talk, Roxana, because that's really helped to set the groundwork in place. Now, I'm going to look at phosphate management, but I'm going to look more broadly at diet as a whole as such a powerful tool in the management and helping to minimise cardiovascular disease in children with chronic kidney disease. What I aim to for you to get out of this time now is for you to gain more clarity on why early dietary intervention is so crucial, and to look at how we as clinicians have such an important role and can impact the future of the children that we're working with. And then I'm going to very, very briefly give you a few insights from my own PhD, which was an exploratory study, a mixed method study, looking at individuals' perspectives on the development of an early dietary phosphate self-management strategy. Chronic kidney disease can have many devastating long-term consequences, and we're all very aware of this. Clinical complications of CKD can be presented as having a double perspective. And this graphic just helps to show the correspondence between some of the early clinical signs, which many of us are aware of, and the complications that develop as the children grow, and then the consequences in adult life. Starting with anemia, we know that its effects on the efficient transportation of oxygen around the body can place huge strain on the heart, progressing to left ventricular hypertrophy and cardiovascular disease. Hypertension caused by many changes in the renin-angiotensin system, affected by sodium retention, and causes sodium retention, and consequently affects fluid overload, which cumulatively can result in hypertrophy of the heart muscles. We know that CKD causes a disturbance in growth hormone and IGF-1, and we're all aware of the inadequate nutrition, and our key role is trying to optimize the nutritional intake in our children. But we know the impact this has and the influence of growth failure and short stature. Metabolic acidosis is something that I will be touching on later on when I look at a dietary approach that we may want to consider. Metabolic acidosis is characteristic in patients with CKD and inhibits pituitary secretion of growth hormone, downregulating hepatic secretion of IGF-1. Medial calcifications, as Roxana has touched on, or stiffening of the elastic layer of the arterial walls, is associated with increased cardiovascular mortality. And something that's very familiar to all of us is CKD-MVD, and the awareness of our patients of the early changes that are taking place and the abnormalities that are already in place in the very early CKD stage 2 that can compound and affect hyperphosphatemia, resulting in early bone changes, fractures, and cardiac calcifications. Now, I think you'll notice here that the dominant complication is cardiac related. And so it doesn't take a lot for us to realize that it's really such an important message that we try to put in place what we can as early as possible to try and prevent these early signs that can cause the development of cardiovascular disease in these children. Now we can see in this US study of over 23,000 children who started dialysis at less than 21 years of age, and this study gathered the data between 1990 and 2010, and they looked at the cause of mortality by age at treatment for end-stage kidney disease. And I just want to focus in on the crude mortality rate here per 100,000 person years. And you can see that cardiovascular disease was the main cause of death in over a third of children under 5 years of age, and in almost 14.5 of those over 5 years of age. So it's quite stark findings, really, that this is something that we're really trying to prevent. In this European study, again, it shows that cardiovascular disease is one of the main causes of death across all modalities, but particularly in those experiencing or undergoing hemodialysis. Changes in arterial structure and function have been identified, and Roxana mentioned the Wesling-Perry study in 2012, and we can see those early mineralization changes in CKD2. But this recent study shows that they've identified arterial structure and function changes in young pre-dialysis children and found these to be causally associated with cardiovascular mortality. Arterial changes reflect the osteoblastic transformation of the vascular smooth muscle cells caused by early dysregulation in phosphate metabolism, with an upregulation of bone-forming proteins such as alkaline phosphatase and the production of osteoblasts in the cardiac vessel walls. We're very aware that phosphate is the main vascular toxin in CKD. But we also know that other mechanisms are in place in early CKD MBD, including deficiency of clotho, vitamin D, increased circulating FGF23, and secondary hyperparathyroidism, all of which play a key role in the cardiac calcification process. Now, what I've listed here are some of the key traditional and CKD specific cardiovascular risk factors that our children are exposed to. And I just want to focus in on the CKD specific cardiovascular risk factors and just ask you to consider yourself, how do you as a dietitian or a clinician traditionally address many of these concerns? So if we look at hypertension, just waiting for it to respond. So hypertension, we normally think of considering salt, so encouraging them to follow a no added salt diet. And importantly, to reduce the amount of processed foods in the diet. And this is where we want to champion home cooked foods where they're preparing from fresh. Are you able to move the slide on, Lucy? Or not? It's just an addition in this slide, actually. Doesn't seem to be responding to me. And then CKD MBD. The key approach there is that we want to look at phosphate, particularly in the early stages, so as early as possible. We want to look at where the main sources of inorganic and organic phosphates. And we know inorganic phosphates are those that are added generally by manufacturers. And the bioavailability of these two different types of phosphate sources are hugely different. So the natural organic phosphates, which we know are mainly found in milk, cheese, yogurt, eggs, meat, have a bioavailability of about 40 to 50%. Whereas in the unnatural inorganic sources, the body absorbs almost 100% of them. So these are the key phosphates that we want to target and get rid of in the diet, and try and reduce and encourage a significant reduction in processed foods. But we also need to be really mindful of the calcium and the vitamin D, and the whole picture is really of priority to us. Oxidative stress. So this is something that's becoming, I think, more, I guess, in our frame, and we need to really give it more consideration. And this involves looking at how we can optimize antioxidants and anti-inflammatory products, so particularly the increase in fruit and vegetables to reduce free radical formation. When we look at inflammation, we want to be looking at the good fats, so the N3 and the N6 polyunsaturated fats, mainly found in fish oils and vegetable oils, and whole grain cereals, nuts, seeds, meat, soya, and eggs. Now, this message seems to contradict itself, but I'll just bear with me and you'll see where I'm going with this. Because this can often really be a challenge for us as dietitians, because when we're trying to reduce 7-phosphate, we know that it can compromise many of these really positive components that are providing really good antioxidant, anti-inflammatory, and good fats. And then lastly, the uremic toxins. And we know that this can contribute to metabolic acidosis. And the increased acid production and the reduced excretion and neutralization ability of the kidney is affected by the amount of acids in the diet. And one of these main means of acid is the amount of protein, which is the key source of phosphate in the diet. So I want you to just, oh, you've done it already. That's very interesting. So just to find out your thoughts, really. So we're split completely. That's really interesting. We're changing all over. So most people feel that the healthy eating message could be relevant across all stages of CKD. So that's really, so let's just explore this together, because I'm really excited about this whole area, and to think it really does. It goes in the face of what we've all done for years and how we've managed these children. And so it's really for us all to be open to reconsider, you know, should we be thinking of a different approach? So first, I just want to look at this earliest biomarker that we have, FGF23, which is released by the bones. And we know that this is something that isn't currently available and isn't currently used in clinical practice. It is used in research, and I'm hoping to be involved in a study in the near future where we'll be using FGF23 in some of our early stage CKD patients. But in this study, in this recent study, a group of 73 children with all stages of CKD 1 to 5, and a small group of 14 healthy age and gender matched children and young people, there was an upward trend, and you can see that clearly here, this upward trend in FGF23 as CKD progressed. So we know that when there's an upward trend in FGF23, there are changes taking place in the bones. There are abnormalities already starting to mount up. And we know that FGF23 directly correlates to CKD progression. So as FGF23 rises, we know that there's an acceleration of the progression of the disease. In this Egyptian study of 40 children and young people with CKD 2 to 4, and then these were age matched with 20 healthy age and gender matched children and young people, they were able to demonstrate a positive correlation here between FGF23 and carotid artery intima media thickness, which Roxana mentioned in her talk. So you can see that there are changes in the thickness of the cardiac vessels as the FGF23 level is starting to rise. And they propose in this study that FGF23 may be used as an indicator of subclinical atherosclerosis in children with CKD. So diet is key. It's such a powerful tool, and it's in our hands. And we as educators, dietitians, have got to, I think, rise up, step up to the mark and actually start to intervene as early as possible, because we know that we have such a key message to deliver. So diet has a key role in cardiovascular prevention. And currently, we're all aware there's a growing trend towards a vegetarian or a plant-based diet. So I wanted to explore what the literature has to say about this. A plant-based diet is associated with many cardiovascular benefits due to its association with a lower BMI and blood pressure, a reduced occurrence of hypertension, and improved lipid profile. Plant-based diets are rich in anti-inflammatory components and have a high capacity to neutralize free radicals due to the high oxygen radical absorption capacity. And we know that they're rich in whole grains, which are high in fiber and proteins. So while valuing the rich high biological value proteins in meats and fish and cheese, and the heme iron and the magnesium, zinc and B vitamin content of animal foods, they can be a rich source of saturated fats. Whereas plant-based foods contain a rich canvas of micronutrients, apart from, as we know, B12, and they're a source of healthy fats, mainly monounsaturated and polyunsaturated fats. They're also rich in fiber and phytochemicals, which are directly protective against cardiovascular disease. And plant fats have cardioprotective properties, unlike animal fats. Now, in this the largest known study of diet and disease, the EPIC Oxford study, which was recruited to date, it's still ongoing, recruited over 500,000 healthy men and women, and over 27,000 of these are vegetarians and vegans. So each participant was asked to complete a dietary questionnaire, either self-administered or used via interview, plus a 7-day food diary. Blood samples were taken, anthropometric measures were taken too. And the group was divided into 4 different dietary preferences. So there was a meat-eating group, fish eaters, vegetarians and vegans. And the findings shown, you can see this here, we've got the males and the females. And you can see just the 4 different groups. So vegans, vegetarians, fish eaters and meat eaters. And the age-adjusted mean BMI was significantly different between the 4 diet groups, being highest in the meat eaters and lowest in the vegans. And the high protein and low fiber content of the diets were believed to be the key factors most strongly associated with an increased body mass index. And regular consumption of processed meat as the main animal-derived source of protein increased individuals' risk of cardiovascular disease. So looking at the long-term relationship between where we're getting our main sources of protein and therefore our main sources of phosphate from. So in this atherosclerosis risk in community study, the ARIC study, this particularly looked at the risk for chronic kidney disease. Now this is all adults, there's a lot of adult studies. I'll draw upon a few pediatric studies, but there's just not a lot of pediatric studies looking at this. And mainly because of the ethics of actually trying to manipulate children's diet. It's really not easy. So in this study, which is a community-based prospective cohort study of almost 16,000 adults from 4 US communities, all participants were free from cardiovascular disease, diabetes, and had a GFR of greater than 60 mils per minute, 1.73 meters squared at the start of the study. Now, during the median follow-up period of 23 years, over 2,600 of the participants advanced to chronic kidney disease. And the findings showed that red and processed meat intake were associated with an increased chronic kidney disease risk, and that vegetables, nuts and legumes were protective against chronic kidney disease. So let's look at what we mean by a plant-based diet. It can mean different things to different people. A plant-based diet, despite containing low amounts of protein, is also rich. It's also rich in potassium, phosphate, and therefore is often believed to be unsuitable for individuals with CKD. However, there's a growing body of evidence demonstrating that such a diet can be beneficial for CKD patients when they learn how to use it wisely. Nowadays, there are numerous types of plant-based diets, including lacto-ovo vegetarians or lacto-ovos, vegans, fruitarians, and many more. Now, some of these diets combine a plant-based diet with an animal products such as egg, milk, and honey. Others are more fruit-based or sprouts or juices. However, regardless of the type of vegetarianism, such a diet we know is typically contains large amounts of whole grain cereals, nuts, fruits, and vegetables, and is rich in dietary fiber, folic acid, potassium, magnesium, vitamin E, vitamin C, the carotenoids, and many phytochemicals, as I've mentioned. But just looking at this definition here on the left, in the context of CKD, a plant-based diet can mean something different. So it involves eating mostly whole grains, fresh fruits and vegetables, legumes, beans, peas, and lentils, unsalted nuts, good oils, healthy oils, to steer away from processed foods, to try and reduce refined grains, limit the snacky foods, crisps and cookies, and reduce the amount of sugar and carbonated sugar beverages and carbonated drinks. And then meat, fish and poultry and other animal products are really important, but need to be managed in terms of how often and how much they're consumed. So let's look at some studies. Again, these are adult studies, but they really help us to get some insight to what happens when we manipulate the diet. So in this first study by Mo et al. In 2011, so these are really small studies. This is a crossover study involving 9 participants with CKD stage 3. So by substituting the plant-based protein and therefore the source of phosphate, so the protein was coming from, so they substituted the plant-based for the animal-derived protein, they were able to improve metabolic acidosis. And this then reduced, it shows that this had a big impact on the status, the serum status of different levels, which I'll touch on. So the impact of this study, so using the grain-based diet, then the meat-based diet, each diet was followed for 1 week. The grain-based diet demonstrated a statistically significant reduction in FGF23 level compared to the meat-based diet. And this clearly affirmed the FGF23 lowering potential and capacity of plant-based diets with its rich content of low bioavailable organic phosphate. So you can see there was a significant reduction in the FGF23 pre and post, and much greater in the grain-based diet. Now, similarly, in the randomized control crossover study by Delorio in 2012, the protein consumption was altered using a very low all plant-based diet and a low protein diet using a ratio of 1 to 3.6 gram ratio of plant to animal-based protein source. And then, acting as their own control, patients switched to the alternative diet. And the reduced consumption of protein from the plant-based very low protein diet resulted in a significant fall in FGF23 levels. So I'm sure many of you are thinking, but this is not what we want to do in children, and I completely agree. We're not wanting to encourage very low protein diets. But what I want to challenge you about is where the protein is coming from, and whether we should be focusing our attention more on trying to get more of the plant-based protein into our children's diets rather than more of the animal-based proteins. So in both of these studies, there was no change in plasma calcium, sodium, or creatinine level between the 2 diets. But interestingly, and this relates to the next part of the talk, they also looked at the urine pH, and they found that it was lower in the meat-based diet, obviously with a pH of 6.6 being more acidic, versus the vegetarian, which was more of a neutral pH of 7. So how does this translate to children's diets when we want to optimize their protein for growth? And are there alternative renal protective sources of protein that we should be considering? Now, soya consumption has been shown to be beneficial in patients with CKD, and it's been shown to provide cardiovascular protection and decrease proteinuria. In this meta-analysis of 9 trials involving 197 subjects, they demonstrated that the intake of soya protein significantly reduced serum creatinine and serum phosphorus concentrations. Moreover, there was a significant reduction in serum triglycerides without affecting their total cholesterol or calcium levels. So just focusing on one of these studies in the meta-analysis, let's go back a minute. So this was a crossover randomized controlled trial that was conducted amongst 14 patients, so 10 men and 4 women. They were put into one of 2 groups. So one diet contained 0.8 grams per kilogram of protein, which comprised 70% animal-derived protein and 13% vegetable-derived protein. And then in the second group, a similar diet contained the same amount of protein, but the source was 35% from animal protein and 35% from soya and 30% from other vegetable protein sources. And these 2 diets were prescribed in each phase of the trial for 7 weeks. And there was no washout. There was a 4-week washout period between the 2 phases. Now, what they showed was that the consumption of soya protein reduced urinary urea nitrogen, proteinuria, blood sodium, and serum phosphate compared with the more animal-based protein diet. And that serum and urinary creatinine, blood urea nitrogen, serum calcium and potassium levels were not significantly affected in the soya protein versus the animal protein consumption. Now, many of you might be saying, but soya products can be, a source of phosphate, potassium, and sodium. And yes, they can. And so it's really important that we consider how we can introduce them in moderation, but they can be a valuable part of a plant-based diet. And there's a growing body of evidence suggesting that the source of protein, so whether it's animal or plant-based, may be more important than the quantity of protein consumed. And that meat products, because of their greater dietary acid load potential, may be something we need to consider. So let me just bring you on to this work that Caroline Passy has done a lot on. And I'm just going to unpack what she's found. So this is all work that's done in adults, but then I'll touch a little bit on what I aim to do in the future as part of a postdoctoral fellowship. So the key messages underpinning this alkaline diet are that dietary proteins are the source of nitrogen, phosphate, and are key sources of dietary acids in the dietary acid load in the body. So when protein foods are metabolized, obviously there's a breakdown of amino acids. Most release acids, therefore we get a release of hydrogen ions. Now the amount of acid that's released depends on the type of amino acids present, as some amino acids are more neutral, others alkaline, and others more acidic. And the examples I've given here, so for example, lysine, arginine, and histidine are acidic and break down to hydrochloric acid and glucose and urea. Cysteine and methionine contain sulfur and therefore break down to sulfuric acid, glucose, and urea. Increasing fruit and vegetable intake has been shown to reduce dietary acid load, reducing kidney damage and slowing disease progression, and thus is protective against cardiovascular disease. Now, most fruit and vegetables, when metabolized, produce alkaline, which neutralizes the acid that is also produced by them. So fruit and vegetables contain organic acids such as citric acid and organic salts such as potassium citrate. So the organic salts present work by mopping up the hydrogen ions which are produced from the organic acids to produce carbon dioxide and water. So it's worth noting that phosphate-containing foods, whether natural, so organic, or inorganic sources, can add to the dietary acid load, and this reflects the type and the quantity that's in the diet. But it's important that we know that fats and sugars have little effect on the acid balance in the body, and we know that these are key sources of energy in our growing children. So the main focus of the alkaline diet involves a balance between the amount of acid produced by the body, what's called the potential renal acid load, and the kidney's ability to get rid of the acid, so this acid-base balance. Now, kidneys help to maintain this acid-base balance by three key mechanisms: the excretion and neutralization of acids, and also the excretion of anions or alkalines. So let's just work through this and just explain to you what happens. So if we start from the left-hand corner now. So a typical Western diet, we know, releases about 55 to 110 milliequivalents of hydrogen a day. So that's the amount of acid that's released. And that's mainly because a typical Western diet is high in protein, high in phosphate, and low in fruit and vegetables. Now, in comparison, a vegan diet produces minus 50 milliequivalents of hydrogen per day. So a huge difference there. So in addition to this acid load, we've also got the amount that is produced during endogenous metabolism. So that's here. So 35 to 60 milliequivalents of acid that's produced. So let's look at this. So if we take the lowest figure, so if we've got an individual that's got, if we take an individual with CKD who's probably got a similar diet to this, so probably at the beginning quite high in protein, high in phosphate, and low in fruit and veg. So they'll have, we'll say, about 50 milliequivalents. They could have much more. And then they've got this extra amount of acid produced from endogenous metabolism. So they've got a total here of the 55 to 110. Now the role of the kidney here is it's got to try and excrete this acid. Now our normal ability, if you've got a normal GFR, is about 45 milliequivalents that are excreted a day. But as your GFR drops, your ability to excrete the acid is significantly reduced. So in order for the dietary acid to be excreted by the kidney, it's reliant on the secretion of angiotensin II and endothelin. Now, the increased secretion of these hormones, we know, causes an increase in kidney damage and disease progression. Now, the amount of acid excreted is adversely affected, as I've said, by a fall in GFR. So moving on to this bit, so if we're not getting as much release, we've got this residual amount of acid between 35 and 90 here, based on these two possible options. We then need to try, and if we can't excrete it, the kidney tries to neutralize this acid through the metabolism. Here we can see of glutamine in the proximal tubule, which is broken down to alpha ketoglutarate. So the waste product of alpha ketoglutarate is ammonium. Now, alpha ketoglutarate, what happens is it accepts the hydrogen ions as it's metabolized to glucose, and then it gives off ammonia as a waste product. But it can take several days to achieve the maximal excretion of ammonia. And the accumulation of ammonia in the kidney increases damage to the kidney. So the body still needs to get rid of this acid. And the next option it's got is to try and exchange some of these, or to try and draw some of the hydrogen ions from the bones and from the muscles. And this is where we see the bone damage taking place. So the bones and muscles are lost in order to neutralize the acid. The acid reacts with the bone and connective tissue in exchange for hydrogen ions, thus contributing to mineral and bone disorders. And likewise, muscle protein is broken down to neutralize this dietary acid. And then the next option, or the next consideration, is the excretion of certain anions. So some organic anions or alkalines, like oxalates, which are found in spinach, are excreted in the urine. But when the urine is very acidic, as can be the case in individuals with CKD5, some of these anions will be excreted in the urine with hydrogen ions as organic acids. And this can add to the amount of acid and the titratable acid load. And it's been suggested that until we have a better understanding of the impact of these high oxalate foods, they should be discouraged in the diet. But what's worth noting, and I've just put this down here, is that some vegetables, such as potatoes and squash, have a high alkalizing ability. So that means they're able to attach themselves, so they give off a lot of, they're able to attach themselves to these hydrogen ions and try to reduce the acidity. So they're really protective. Also, salt, we know, is something we want to get rid of because this increases the acid load. And metabolic acidosis has been shown to be associated with increased cardiovascular risk. So Caroline Passy then actually looks at what does this look like in terms of a typical diet, but some of the key foods. So I've put here what are some of the acid producing potential of certain foods. Now you can see that cheese is very high, likewise meat and fish. But whereas vegetables and fruit have a negative potential renal acid load. And some certain phosphate-based acids, phosphate-based additives are acidic, so such as calcium acid pyrophosphates, which are used in meat and potato products. So these can really add to the acid load. And so the key message here again is about getting rid of processed foods and really trying to increase and encourage people to cook from fresh. So what does this look like when we try to put it into practice? Again, this is based on an adult's diet. You can see there, they encourage the amount of protein, potatoes that are encouraged each day, 2 to 3 portions of vegetables, 2 to 4 portions of fruit, a controlled amount of milk, and then 50 to 100 grams of meat or fish a day, lentils, beans, whole grain cereals, so they favour those because they've got a lower potential renal acid loads, encouraging good fats, allowing sugars and preserves, but limiting those which produce oxalates. Certain vegetables like peas and sweet corn are more acid producing, and then carbonated drinks have a high, often phosphoric acid. Sorry about the background noise, I'm at the hospital here. So the total potential renal acid load can be, using this diet, can be between +5 and -15, but with a protein intake between 35 and 57 grams per day. But I'm sure many of you are saying, but how does this affect the potassium intake? And rightly so, and Caroline raised this as something that can be a challenge in many individuals with advanced chronic kidney disease. And she encourages individuals to carefully consider each patient's needs, to look at their medication. Are they on potassium-sparing diuretics? Because this can limit their ability to alkalize the diet. Looking at their serum potassium level and their overall dietary intake. So it's advising on, tailoring a diet to their needs and looking at how you can make use of this approach, but making it individual. So this whole concern about hyperkalemia was something that I was a bit dubious about when I looked at the alkalosis diet, and I then wanted to explore further. So in this study, this actually looked at the DASH diet. So I'm sure many of you are familiar with the dietary approaches to stop hypertension diet. Again, it's a study in adults. But the principles of the DASH diet are not dissimilar to the alkaline diet. You can see the encouragement of whole grains, good fruit and veg, controlled amount of dairy products and meats, good healthy fats. So in this study by Tyson in 2016, they aimed to test the effect of the DASH diet on serum electrolytes in adults with moderate CKD. And compared with baseline, the DASH diet modestly increased the serum potassium at 1 week, but it had no significant effect on the serum potassium level at 2 weeks. And during the study period, there was no recorded incidence of hyperkalemia or new onset metabolic acidosis that they observed. Oh, we've got a bit of an overlap here. Something happened there, Lucy, to the slide. I've got slides coming over the top of other slides. So I just want to very briefly now just explain a little bit about my own study, and then we're almost there. I'll tell you what I plan to do then in the future. So I undertook this mixed methods study where the first phase I did a mixed study systematic review with a narrative synthesis. So I wanted to look at how diet is currently used across chronic diseases in the early stages to help manage the chronic disease. And then I wanted to learn from all these other disciplines and see how we could draw upon that in the management of children with early CKD. So that first phase was then used to inform an exploratory qualitative in-depth interview with children and young people, parents and healthcare professionals. So I then interviewed a total of 21 individuals and just explored their perspective. What do they see as important in those early stages? Do they feel that by introducing some dietary intervention early, is that imposing or is that empowering? Is that putting more tools in their hands that gives them more control over what they can do with their child's condition and with their family as a home? Do they feel that they're being given some control back? And it was a really interesting experience. And then the qualitative analysis of that data led then to the development of 48 statements for an online 3-round Delphi survey. And the outcome of them would help me to put into place some early modelling for the operationalisation of an early phosphate self-management strategy. So just to pluck out a few of the statements that were made, and you can read for yourself some of these comments that were made. So these were 2 from healthcare professionals who I interviewed. And their main focus, they said reducing phosphate intake is probably one of the major triggers for long-term bone conditions and is associated now with cardiovascular disease. But it's far better to try to ameliorate the diet at an early stage. And that's a long-term education process. I believe we should strongly get diet is involved early. Now, the message that came from that is we're the educator. It's a long-term educative process. Often we're used as firefighters at the end. We're coming in to mop up the deranged biochemistry, but we really need to be getting in much earlier. And then the second statement said, the only thing that we can do is give them medication. So give them alpha-calcidol, maybe treat their vitamin D, but we're really not tackling the root of the problem, which, as you know, where the phosphate is coming from, what's driving the PTH. We really do need dietetic input early. So they really emphasise this focus on long-term education and getting to the root of the problem. And it's a long-term journey and that we need to be doing it together, getting in right at the beginning. So in one slide, this is what I concluded from my PhD. So the stakeholders that I interviewed and that I engaged with in the Delphi, they felt that there's a need to reframe the whole early intervention strategy. So early phosphate, also they felt it was much wider than early phosphate. They said, you can see here, they labelled it as we need renal healthy eating, and that's what we should be delivering early. So they felt that it should come in 2 approaches. They said in the early stage, we all want to be part of a culinary workshop, which is delivered by the paediatric renal dietitian and other healthcare professionals. And at this workshop, they want to be given education, support and upskilling, because we know that many families struggle. We know that we tell them what to do, but they don't know how to do it. So it's really to support them, empower them and help them to be able to put these simple changes into place. And this will then help them to translate the complexes, but to make it individual, this dietary advice, into an actionable plan. But also these early culinary workshops will help to build trust and engagement so that they can get to know other families and start to build good, solid relationships with the healthcare professionals. But it shouldn't just be that child and their parents. We want to make it more inclusive. So it's inviting more of the family change agents who are involved in delivering food. So it's not just looking at the phosphate measures, but it's much wider. And they felt, the stakeholders strongly felt, that the dietitian and the consultant should offer a joint consultation during the diagnostic period. Diet should be on the cards at diagnosis. One young person said to me, it's important we have some breathing space. When you get a chronic diagnosis, it's overwhelming. But he said to me, but I still feel that the dietitian should be there in those early few weeks and months. They should be part of that early engagement. And that the main message should be that we're promoting kidney health early on. And this should be delivered in multi-platform levels. So using online, using face-to-face. Now, we want to use what is currently available as clinical markers and assessment tools, but the main thing is we want to increase the awareness and increase the understanding of the power of diet in the early stages. So where am I going? So what I'm wanting to do is to draw from all this insight and so much more that I've got to learn. But I feel that there's mileage in looking at how we can encourage individuals to cook from fresh, but to have more of a plant slant. So I'm looking to prepare a feasibility study which will inform a randomised controlled trial, and we've named it the CKD 123 Protect diet. So the 123 reflects 1/3 animal-derived protein and 2/3 plant-derived protein. So the main message that we want to try, when I guess work out what this diet looks like for many of our children, and it would be really focused on the early intervention ones, so those are CKD 2 and 3. So we want to, the main message is to increase their fruit and veg, but particularly the alkaline producing fruit and veg, to reduce their meat intake, but make sure they've got adequate for their protein requirements, and to maybe have to focus on having a meat-free day. And that may increase the amount of soya on that day. So it's just a small amount, but a controlled amount of soya in their diet, to get processed foods out of their diet. And that's not easy. I don't say that glibly because I know that's not an easy thing in my own children's diet. But to then encourage good, healthy fats and oily fish, to cook from fresh, and to encourage whole grains, because although they may have a higher phosphate content, their phytate content means that the bioavailability is much reduced. So if you look at, say, white bread or wholemeal bread, the white bread may have a lower phosphate content. However, the wholemeal bread, the amount of phosphate in it isn't absorbed as effectively. So actually, the net amount of phosphate that's gained is probably the same, but you're getting all the benefit from the fibre, which is really protective against cardiovascular disease. So I hope I've given you some food for thought, and over to you. What do you think?